Hi, and welcome to episode 173 of the Untethered podcast. Today we have Dr. Tiffany Lamberton joining us. Dr. Lamberton has dual degrees in physical therapy and dentistry, both from Loma Linda University in Southern California. She has a passion for diagnosis and treatment of temporomandibular joint disorders using an imaging-based solution model. She has limited her general dentistry practice to TMD and Airway awareness in the greater Seattle-Tacoma area in Washington State. She's a creator of TMD Collective, a space to guide, educate, and create community for individuals experiencing TMJD. Dr. Tiffany is a member of AOMT, Spear Education, the Chicago Study Club, and a board member of the Pierce County Dental Society. She loves Pilates, wake surfing, snowboarding, and lives in Tacoma with her husband and 2 children. Quick disclaimer, all information, content, and material of this podcast are the opinions of the speakers and is for the informational purpose only and not intended to serve as a substitute for the consultation, diagnosis, and/or medical treatment of a qualified healthcare provider. Welcome to the Untethered podcast. I am your host, Hallie Balkin. I'm a certified orofacial myologist, feeding specialist, and mentor. This podcast is all about getting your questions answered and collaborating with colleagues to bring you the most up-to-date information in the orofacial myofunctional therapy, tethered oral tissue, and airway space. I challenge you to keep an open mind and join my mission to get this information out to the masses. Let's get started. Well, Tiffany, thank you so much for joining me today.
Thank you so much for having me. It's really an honor to be on the Untethered podcast today.
Oh, thank you. I'm excited because I know that we kind of met through a virtual study group. And when I heard about what you were doing, I was like, oh, we have to talk more. Like, it's so hard to find, professionals who have your background. So will you share with us a little bit, about you and your story and kind of how you found your niche?
Sure. So I'm Dr. Tiffany Lamberton. I am in the greater Seattle-Tacoma area in Washington State. And I have dual degrees in physical therapy and dentistry. And so I was a physical therapist first, practiced mainly doing a lot of orthopedic, sports medicine. And then I got married and moved to Southern California, and my husband was in medical school. And I was like, oh, I think I want to go to dental school. So in dental school, which was an amazing, challenging experience, I just kept thinking, like, when are we going to talk about the temporomandibular joints? I think we had like 2 days maybe of, a little bit of curriculum, a little bit of observation, but just, we're just, as dentists, I think we get so focused on the teeth that we don't always like back out and kind of see that big picture. And so I remember, in dental school, a couple rotations where, it seemed like the dentist that had gone on to a residency in TMJ, she's doing a lot of appliances and splints and a lot of like spray and stretch. But like I said, again, just like as a general dentist, not a lot of like instruction and hands-on of like, what's going on? What's your thought process? What are we doing? How do we treat these patients? It was more like, okay, let's get that perfect prep, that filling just right. So anyway, fast forward, after dental school, I went to a big meeting in the California Dental Association, and I heard who's now my mentor, Jim McKee, speak in San Francisco. And it was like, light bulb. I was like so riveted by, kind of the way he was presenting that. And so I also heard Dr. Mark Piper speak, who is an oral surgeon and MD in St. Pete's, Florida, and who's done just a ton of like joint surgeries and really like microsurgery. And so I kind of summoned up my courage to go talk to Dr. McKee afterwards. I had my cute little outfit on and I was like, hi, I'm Tiffany Lamberton. And he's like, come out to Chicago. And I was like, what? He was like, yeah, come out. And I was like, really? He's like, yeah, you should. So I went out there, I shadowed him at his office. I went to the study club, and it just was like, again, it made so much sense to me from kind of like a PT's perspective that it's not just about the teeth. We really have to think about kind of that big picture. And so, in the meantime, I'm kind of having my own kids, and I'm starting to kind of see some of the things with Airway. And that was, kind of more like 2016, when I had I got introduced to the AOMT and started to kind of like find out a little bit more about myofunctional therapy. And so then I'm looking at my own kiddo, watching him sleep, and I'm like, he's grinding his teeth. He's got dark circles. He's, wetting the bed. He's mouth breathing. He's, got all these things where, and then I start looking at tongue tie. I think he might be tongue tied, and so I guess just like as a parent, it's so hard to kind of navigate, who do you go see? So for me, it was like, you go to the pediatrician and they're like, oh, kind of kick the can down the road. Like, oh, he's going to kind of grow out of this. So like, go to the pediatric dentist, like, oh, I think he's fine, So like, I feel like as a professional, I really had to push hard to kind of build that interdisciplinary team. And really as a parent, I just want to like empower other moms to like be relentless in your advocacy of your kiddo. And when I was listening to one of your podcasts, you had said, you were sharing kind of like your daughter's story, and you said, we got to this point and I just hit this myo wall, right? So she had gone through expansion, you kind of gotten that piece in place, but then when you get to sort of like that AP correction, and that's where I really feel like the temporomandibular joints come into play, because once you start to kind of see that phenotype, you start to see that profile of like, especially the kiddos that are really retrognathic or they're class 2, maybe they have that anterior open bite where the front teeth won't couple together. You've got to dig a little bit deeper, right? And so, in my case, I pushed hard because my brother-in-law is a sleep physician. And so we did the sleep study, and my kiddo was having like 17 events an hour. And like, I literally was about to burst into tears, because I'm like, here I am, this is my thing. I understand this. And like, it's happening in front of my eyes. Right. Yeah. Oh. So again, I've been seeing a lot of, I've been taking him to different specialists, to different orthodontists, kind of just trying to decide like, how are we going to tackle this? And so we decided to do an ENT first and do tonsils and adenoids. And at that time, I was sitting out in the lobby during his surgery, and the surgeon comes out and was like, do you want me to just release his tongue? And I was like, no, wait, because we hadn't done like all, as a myofunctional therapist, you're like, you have to do like the work before surgery and after, right?
Pump the brakes, dude, pump the brakes.
Like, no. So I was like, I'm not prepared for that. No, please, like, let's like stay in our lane and just, because it was too overwhelming at that point,
Yeah. Well, and not to interrupt you, but I think another really important point, because this just came up in my membership group last week, was the opinion on, and I guess it's more of an opinion experience with children getting not adenoids, because adenoids is a much easier recovery, but tonsils removed at the same time that they have a tongue tie release. And to that, my question, because obviously I'm not the surgeon, it's not my decision, right? But I've seen children, I've treated these children. These children are in pain. They're recovering from tonsillectomy for a good solid 2 weeks. And so we like to give them that time for recovery before we resume myofunctional therapy, feeding therapy, anything involving the mouth, speech therapy, even, they're swollen, and it doesn't feel good to swallow water when you're that swollen in your throat. So, hydrating them is our focus. We shouldn't have to worry about moving their tongue. So, that's kind of as a mother, and as a professional who has seen this, like, I'm like, even if you are prepared, like, I get it. You don't want to put a kid under anesthesia twice. And if that's your only option, okay, fine. I'm not going to say, no, don't do it. Like, again, it's not my decision. I'm just telling people what I've witnessed in my practice. These kids don't want to move their tongue. So now you've got a tongue. If it does get released, we have at least asked that it be sutured so that we can hopefully avoid the wound, contracting and closing on itself and becoming even more restricted than it was before. But also they need those 2 weeks off. And we typically, even when they are sutured, we when they're sutured, we give them 1 week at most between the procedure and their next session. And when they're not sutured, we see them within like 24 to 48 hours, and they're already educated on what to do during that time, with the ability to reach out to us if they need any help sooner. So, it's very hands-on, which I'm sure, like, you're in the space, you can appreciate that. And it's like, no, as a mother, I would never want to put my kid through that understanding, like knowing what I know. And so that's where, like, even with the prep, I'm just like, oh, can we please separate them out? Like, please. I mean, I get it. I guess a lot of ENTs also are only going to do it under, an anesthetic. So they don't want to give it close together for 2 procedures when they could do it all at once. Like, I totally get the reasoning. And I know not everybody has dentists that do pediatric releases, or oral surgeons that do pediatric releases in their area. So there's so many variables. And I just share that because I know someone's going to be like, oh, you made me feel awful. No, that's not my goal. My goal is just to educate so you can make an informed decision, and whatever decision, like, you decide for yourself or your child, like, that is your decision. And I respect that. But yeah, it's, oh gosh, it just gives me like it just
like flashbacks, right?
Yeah, I'm like, if only I knew then what I know now.
Yeah. Well, and like I said, he was kind of borderline. He's kind of more like grade 3. And so that was also my reasoning for, like, let's just maybe wait and see if we could do it non-surgically. And so we did end up waiting on that, and he still hasn't been released at this point. And again, I think, I may still circle back to that. But I think that that's what's so hard is, trying to find someone who's going to give you that big picture perspective of, like, it's not just releasing the tongue, that there's other factors that are, like, at play here.
Yeah. When it comes down to function too, right? Like, that's, I feel like every time I start to educate somebody who asks a question about tongue tie, just on like a social media post, I'm like working the word function in there, because I'm like, it's not a tie if there isn't impaired function. It's really a tie when function becomes impaired and we have a problem. And if you can improve function without creating all other kinds of compensations, and the person is, healthy and happy and thriving, if we can avoid a procedure, awesome, right? Not always the case. So, I mean, I think I appreciate what you're saying too, because it's like, let's not just cut tissue because we see some tight tissue. Like, let's explore this further and make sure that, like, that's the appropriate next step, even though you could very easily do this right now. Like, please, no, don't do that. Thank you. Moving on. Right. So how is he doing now? Like, how is your son, like, functionally?
Yeah. Way better. And a lot of the symptoms that I had seen initially are improved. And right now, my biggest thing is 2 weeks ago, I took him down to Albuquerque, New Mexico to see an Airway orthodontist. And so again, I had lots of questions like, why would you fly all the way down there? Like, aren't there good orthodontists in your area? And like, absolutely, yes. But again, I like to, kind of think of, it's like a triangle or like a trifecta. You have Airway, you have Myo, and then you have the TM joints or the temporomandibular joints. So I always say, like, the TMJ kind of has like a bit of a branding problem, because TMJ, a lot of people recognize that term, but we all have TMJ. We all have a left joint and we have a right joint. And what we're discovering now with better imaging techniques, with like cone beam CT and MRI, is that those joints aren't always healthy joints on everybody. And, especially with MRI, what we can visualize is the soft tissue, and CBCT, we can do more like the hard tissue. And what we're seeing now is that little fibrocartilaginous articular disc that sits in between the condyle of the mandible and, kind of cushions the condyle against the skull base, is a lot of times that disc is knocked out of place. And in my kiddo's situation, he had a fall on the chin, like straight down in the bathtub, like right in front of me. I'm like, just right then. And then when he was in kindergarten, he had 2 falls on the playground, like literally like a month apart from each other, like concussion, lacerations, so he had some of these things. And then as I'm watching his growth, and, as dentists, we really look at the bite or the occlusion of like how the teeth fit together. And what you can start to see is that one side is not growing right. And so what we found was with imaging is that if that little fibrocartilaginous disc is like a little gasket and it's in place there, and it's really protecting like the growth center of the condyle. So when that disc gets dislocated, it's almost like a fracture of the growth plate, because the condyles are going to drive the growth of the mandible down and forward. And so what ends up happening is if you have an injury just on one side, you'll see one side that gets really short. And so you'll see the chin will point to the short side, and you'll have the short ramus on that side. And then, the teeth will follow, right? Because the mandible, the lower teeth are just going to like follow the mandible. So what I tell people is like, it's kind of like when you have seen a tongue tie, you can't look away from that. It's a phenotype that you start to see, is that you see that really retrognathic jaw that's not growing down and forward. Some people call it like a weak chin. Or you may see it on both sides, or you may see it on one side. And honestly, that class 2 or retrognathic position of the mandible really affects the oral pharyngeal airway space. So, I think that when we talk a lot about like nose, and the maxilla, but also, as dentists, we need to be looking at that, the back of the throat, and like, how is the mandible growing down and forward? And then how are the teeth coupling together? Because orthodontically, you can try to fix the teeth, but if you have a jaw that has an injury that's not, that's kind of lurking beneath the surface that you're not identifying in the beginning, you're not going to be able to get that growth. And so especially females more than males were much more likely to have ligament tearing. So you have kind of a medial and lateral collateral ligament that tether the disc in place. And so different types of injuries, gymnastics, car accidents, so when I do my history, I call it my JPT plus T, but I do a joint history, a pain history, but a lot of times like kids may not have pain. And then I always ask about like previous treatment, like, have you had tonsils and adenoids removed? Have you had that tongue tie release? Have you, what procedures have you had done? Have you had your wisdom teeth taken out? And then, what previous treatment have you had? Have you had orthodontic therapy for expansion, or have they tried to couple the teeth together? And then you've kind of had that relapse of where that anterior open bite opens back up again. And so, we've said a lot of times it's about the tongue, but you think of all the attachments of the muscles, right? Genioglossus, hyoglossus, they're all attached to the mandible. And so if that joint isn't healthy and it's not driving the mandible down and forward, you've got this like piece of the puzzle that I want to like bring into that picture,
Well, and I think the injury, I don't know if we've ever talked about this on the podcast in 100 and almost 70 episodes or so now, like that we like injury to the joint. Yes. I'm just sitting here thinking, well, yeah, of course we look at like infants and toddlers, maybe who have had feeding tube, like an intraoral feeding tube, or, I know like when I went for my nasal surgery, like they use like a donut shaped thing in the back of my throat. It was like an in-office procedure, but it was like 3 hours. And, I was like, like, okay. I haven't had any pain or anything, but like, it's, so it's just all these little things that maybe also we're not thinking about. I had a gymnastics injury when I was little, and I have a maxilla that's turned in on one side up here. And it's just all these things. And I'm like, oh, I wonder when like some of this could have happened. But like injury, like you're basically saying that we have these ligaments, especially females, that could essentially be causing some damage to the joint.
Yes. Absolutely. Absolutely. And I think that the more we start looking, the more you realize like, there is a certain percentage of the population that doesn't have a healthy joint. And when you start putting those patients in like an appliance, maybe it's like a sleep appliance to like pull their jaw forward. I just really, my whole thing is like, let's understand what the temporomandibular joint condition is before we start doing those things, because For me, I was doing a lot of sleep appliances, and I was, you start to see over time that people start to have bite changes, and they start to have jaw joint pain, and they start to have clicking and popping, or, maybe they can't couple their teeth together like they did before. And so I ended up kind of backing way away from, just like, oh yeah, let's just do a snore guard, without going like, okay, we really need to just take a pause and get that really comprehensive imaging. And to me, another component is really like the cervical spine, the upper cervical spine, like C1, C2, and how that is also really like a part of the picture. And so as we're starting to do more imaging, we can see that there's like a misalignment or a rotation, which is a PT. We knew all that stuff, right? Is like, you're looking at the cervical spine and you're like, of course, that's part of the picture. But I think dentists are kind of scared to even like look at the cervical spine. They're like, just go see a physical therapist. So one of the things I want to shoot a little videos of like just some like quick and dirty little like tricks that you can do as a dentist or as a myofunctional therapist or OT speech, just to really like assess that movement dysfunction in a patient, and just add that to kind of like your big picture. So my whole thing is just really creating value for the imaging up front. And I can tell you with my kiddo, having him have an MRI was another barrier, right? It was really, really hard.
Yeah, I can imagine.
It was really hard. So we tried it when he was younger, and he kind of freaked out in the machine. So we're like, okay, we're going to wait a year. So he just had his done about a month ago. He was as a champion. And so basically what I wanted to work with the airway orthodontist is, does he have disc coverage in that position where he can have healthy joints that are ready for growth? And that's the cool thing, is like, if these kiddos are still in that growth phase, that's where, we can kind of catch these issues before they get bad. Right. So when I've limited my practice to TMD or temporomandibular disorders or dysfunction. So a lot of times I'm getting women that are, in their 30s, in their 40s, and they're like, I can't open my mouth more than 20 millimeters, or, I have such severe pain, it's debilitating. You think of like how many times you use your jaw to like yawn, talk, chew, eat
all day long, right?
All day long.
Yeah.
And so when you have like pain, and limited range of motion, and then, it can start to get into, the sympathetic nervous system, and you can end up getting into a lot of like complex regional pain syndrome. And it's very debilitating. And my whole thing is like, my passion is like, let's recognize who those patients are. My mentor used to call it like the deep end of the pool. So who are that small category of kiddos, like before they even start their orthodontia, to correct that AP shift, like, let's make sure their joints are like healthy enough to like withstand, these treatments. Because I just think with the disc and the ligament system, it's like micro trauma becomes macro trauma, so like maybe, I have patients that say like, oh yeah, I used to like, my jaw used to click all the time and then it stopped, and they're like, it's better. And I'm like, well, actually, probably not, because what was happening is like your disc was kind of hanging on, and now it's all the way off.
Gosh.
And now you're on your retrodiscal tissue, which may thin and perforate, and so that's the crazy thing, is like, with CBCT, now that we have better imaging techniques, it's lower radiation than even a panoramic plus a lateral ceph, so if you have kind of those new machines, you can start to see all of this stuff in the skeletal, where you're just like, whoa, okay, this is like, it all makes sense, because the skeleton is not going to lie, and you can try to like fit the teeth, but if those joints are not stable, or they're actively breaking down, it's going to continue to do that, and the teeth are going to kind of suffer. So I just think a lot of symptoms, with like grinding, clicking and popping, we can't like ignore those or sort of normalize those, because those are our little like warning flags, like,
Yeah. So
something's wrong.
can you get more information now, like on these newer CBCT machines? I'm asking because my kids have had imaging through CBCT. Mia just had her first. Lily has had it 3 times. She had before expansion, after expansion. The dentist was very holistic and was like, we don't need to do it after. I'm like, no, I need her case study. So I need to talk about her case. So I'm okay with it. Let's do it. And then I had it done recently at an ortho consult down here in South Florida, at 2 different places actually for both kids. And so we sent off for the beam reader reports too, because I'm a nerd.
I make you beam reader.
I'm like, yes, I'll pay for that. Just give me
yes.
beam reader.
No, they're absolutely fantastic.
What's the point of the CBCT without the beam reader report? It was interesting because on one of the CBCTs with Lily, we had seen what we were kind of like questioning is, we were like, is something going on with her TM joint? Like, is there like, let's monitor this. And then the last one came back and, with reviewing everything, we're like, okay, no, it looks to be very healthy. Like, we think we're good. So anyways, but do you feel like those newer, like you were saying, the new CBCTs can give us more imaging, but can it give us like the full amount of information we need about like the health of a joint for like a pediatric case?
I think it's a really like important piece. I honestly feel like you've got to combine that with the MRI as well, especially in a growing child, because what you want to make sure, especially is like with that class 2 anterior open bite patient, or maybe a cross bite patient, is if the orthodontist is saying, hey, I want to put them into like a Herbst or like a, maybe like a class 2 correction to like bring their mandible forward. I want to know that they have that disc coverage, especially on the medial pole, where they're going to be able to like have that growth happen. And so I really I definitely believe in CBCT, but I think it's important to do the MRI cuts with it as well. So for my kiddo, I kind of did, so Dr. Piper has an MRI protocol, and I did more of kind of like an abbreviated scan with him. So what we did was a bite registration that brought him into a class 1 canine position, and had the tech do like a proton density scan to be able to see the fibrocartilaginous disc. And so now I'm going to be working with my airway orthodontist on like, how do we like work, and kind of plan that case, because, again, he needs expansion. He's going to need that class 2 correction, but we wanted to make sure, because his disc is kind of squirted out to the side laterally, it's been laterally displaced, is that we want to make sure he's in that place where he can get that growth. And what's so cool so the airway orthodontist that I'm working with is Dr. Drew McDonald. He is like a ninja of like cone beam CT and like all the stuff he's doing. And I'm like, I thought I was like doing it comprehensively. And then I was at his office. I'm like mind blown, just like, I mean, he's doing all the things that I am, but just he's looking at everything so comprehensively. And I just think we need to have orthodontists that are like that, that really can, look at the airway space, look at how's the maxilla growing, how's the mandible growing, how is the tongue functioning. So he does all of that in his exam, so we talked about his tongue. We talked about, should we revisit that? And that's why I said we were going to kind of probably like circle back to that. But just really like planning that out, I think in a thoughtful way is going to be the key to really preventing, because like there's like 10 million people in the country and globally that have like TMJ problems, it's a massive problem, and like I said, why are we waiting until it's like all you have is surgery or like a joint replacement? Like, why are we waiting until it gets to that point? I have a good friend who, I like just looked at her panoramic x-ray and I was like, your condyles, instead of looking like a nice, like ice cream cone shape, it's like a stiletto heel, it's like you have no bone, you have like a little bird beak, and so honestly, like even that's what I would say is like, even, the dentists that are just looking at a panoramic x-ray, pay attention. If you see one side that's shorter than the other, and you're looking so closely at like the tongue and like the posture of the, cervical spine. But if you see like this whole shift to that short side, there's a good chance that there's been an injury to that joint and that joint is not growing. So it basically becomes like an osteochondral growth defect where one or both joints aren't growing like they're supposed to. So
it's so fascinating. I mean, we see all the time where just the masseter, right, is clearly being overused on one side and underutilized on the other side. And you can just see that by looking at someone's imbalance. Like it's, and sometimes it's very obvious. Sometimes it's a little bit more borderline. You kind of really have to put your hands on and do some open close, posture to feel it. But we see that frequently. And I know from, creating a myo course and like going through research. And I remember the first time I read that it was like something like 99.7% of all TMD cases have a myofunctional disorder. I was like, well, yeah, that makes sense. I mean, how can you use your muscles properly if your bones aren't like, okay, like, yeah. And so it really kind of just opened my eyes to I'm like, there's so many people walking around, like you were saying, with issues with their TM joint. And it's so imperative in how we sleep, where our tongue rests, how we chew, swallow, speak. I mean, like you were listing it off before. It is a really important joint to pay attention to, but I think it gets like the least bit of attention really in the medical community. I'm like, we really need to pay more attention to it. And I know I've gone through adult expansion too. And, I did get some growth. And then my teeth also tipped a little bit. And so then we kind of like brought them back. We stopped and like brought them back. But, it just made me so much more aware of like this airway myo expansion, space and everything. And I just, I'm like, for the longest time, I've never had pain, but I am somebody who at night, will clench. Like I don't rhyme, but I clench. And I can wake up in the morning and feel like some tension carried throughout here. And so I just had my nasal surgery 3 months ago. And so, I'm still, swelling is a lot more, it's a lot less than it was, but I know it's like, I've still got another 3 to 6 months or so of true swelling to go down. So I'm just kind of like waiting it out to see what happens. But it's something I keep going back to myself because I'm like, I feel like I have enough space for my tongue. I can fit it up there, but for some reason it doesn't naturally want to go there. And I know, like I was saying before, like my maxilla is turned in on one side. I'm like, obviously my journey's not done, but I'm like, I'm like one step at a time. Like you're saying too, I think it's so important to kind of have a plan, an individualized plan that makes sense for the patient based on like what you're seeing, what their symptoms are, their profile, their imaging, that whole comprehensive approach. And, I admittedly just got my tongue tie released. And then I was like, oh, maybe I should have waited till I had more room for my tongue to get my tongue tie released. It's like, that was the beginning of my journey, right? Live and learn. But, it's like sometimes we're really passionate about these things because we've experienced them firsthand,
Absolutely.
Yeah. But it's, one of those things too, that all the time, I'm just constantly going like, okay, I know that they've said that my joint is healthy, but I'm like, what am I feeling on my face? And like, where is the tension? And where, like someone asked me today on one of my posts, like, well, like what's the significance of a upper lip tie, or like what kind of impact is that going to have? Like, why would that cause mouth breathing? And I'm just like, well, let's back it up and think about like what's happening here, right? If the lip is tight and it curls under and it's tense and you're constantly carrying tension, right? Well, now it's not doing its job. So now other areas have to compensate. And if the lower lip can't come up to meet it, maybe it does, but now it starts to cause tension in the mentalis muscle. And then we've got, then we have to think about the other perioral muscles. And then we have to think about the impact up, like it causes this whole big snowball effect. And like, even though your neck is here and your TM joint is here and your chin is here and your,
they're all connected.
Here, I'm like, it's all interconnected. And so when we start to like realize how interconnected fascia truly is, and then the impact that has on our bone structure, that's when I start to see people go like, oh my gosh, like, and obviously what you're talking about is even beyond me. Like I'm no TMJ expert by any stretch of the imagination, but I'm like, it's so fascinating. And I'm constantly just going like, wow, like this is really like, maybe that's why I feel this on the right side today. Okay. All right. Well, document and continue.
Well, and I always tell people, like if your 12-year-old child like had a ski accident and they injured their knee and they tore their medial meniscus, you wouldn't think twice about like if the orthopedist was like, okay, they need to have an MRI before you decide, are you going to do PT and a brace or are you going to have arthroscopic surgery, right? So I don't understand why there's like such like pushback against getting an MRI of the TM joints, because to me, that gives you an understanding of like, you know, what your anatomy is, and then you can decide, am I going to do, conservative things? Am I going to maybe try to do nerve blocks or Botox or PT exercises or, chiro or am I going to maybe consider surgical options or, am I going to consider those orthodontic options? But I just think you have to have that value, you really have to create value for people. And I think that TMJ kind of is sort of that gray area between medicine and dentistry, and dentists kind of don't really want to touch it.
Oh my gosh.
And, we try to like bill medical and like, they don't cover it, so yeah, it's really, kind of been unfortunate because it is a very they're complex joints. And, I really feel like that connection, if you have that disc coverage and you have that connection, that's going to influence your maxilla, the growth of the maxilla as well. In our young growing children, it's we really need to have that connection, that synovial joint be like functioning properly. And I think with kiddos, they don't always have pain, but you start to see those little subtle signs, you start to see that little S thing as they're like opening and closing. Maybe they'll get like a little deviation, as they're opening and closing, or like I said, you look at the bite and you start to see that anterior open bite where the teeth don't couple. And you're thinking like, maybe, that's why I said, I loved on the podcast, you said, I hit a mile wall with my daughter where she'd had a release. I have her where, but she's still not quite where I want her to be. Right. And kind of like that sagittal plane, when you're looking at kind of the growth and development. And, medical modeling tells us that even that little shift from a class 1 to a class 2 bite decreases the oral volume to like 92% from 100%, so already those little class 2 kiddos that have that retrognathic, presentation, they're already not getting as much oxygen, even if they've had the tonsils and adenoids out. So that's my whole thing, is just like, I want people to think about kind of, that other piece of the puzzle, like, let's not leave the joints behind. So, kind of my thing was, I started TMD Collective because I had so many clients, kind of like crying in my chair, like, why didn't anyone ever explain this to me? I want to know, like, why did I have to wait till it got so bad that I can't open my mouth, or like I have this closed lock I can't open. And so I just really feel like in order to make it better for the individual, we have to make it better for the collective. And so I feel extremely passionate about just getting my message out there, that we have to really take that comprehensive look. It's part of myo, it's part of the cervical spine. We all, it's like, we all have to collaborate. Yeah. I'm like, let's all get along.
Yes. Wouldn't that be so great? So the TMD Collective, who is that for? Like, where can they tell us where you can find it?
Yeah, so I do have a website. It's www.tmdcollective.com, and that's mainly for people, kind of in the greater Seattle Tacoma area. If they want to see me in person, I'm taking new clients, but kind of staying tuned. I'm hoping to do, like I said, maybe a master class for kind of like myofunctional therapists, or I'm going to be speaking at the PNDC, which is like the Pacific Northwest Dental Convention in November, which is like our big dental meeting. And it's going to be Airway and myo and TM joints.
Yes, that's so exciting.
If anybody wants to come see me, November 10, I think 10 to 12 is in Seattle, our big meeting there. But I'd be happy to do any like small group study clubs. You can email me if you want more information. I am also on Instagram at TMD.collective, because like TMD Collective was taken. So, but that's the platform I'm probably like the most active on at this point. Like I said, I'm just kind of getting started, but love to hear feedback from your community if they want to like hear more information, or, reach out to me. We can bring you
into the Myo membership and have you present to the myofunctional therapists in there. We have over like 450 monthly members right now, and we're about to reopen doors. I don't know when this will air, but July 18th, week of July 18th, doors will be open so that they can join us too. So
Awesome.
we'll have to see. I know I'm pretty sure we have like maybe at least 1 month still open this year, but we'll confirm with Jess. But yeah, I think this would be so informative because, you know, we are constantly looking for like airway forward providers who, you know, even if you don't even, I mean, you have an understanding of myo, but like, even if providers don't have an understanding of myo, but they collaborate with myo and they understand airway, I'm like, we can all come together, learn from each other, and it's just going to benefit our patients. And one of the most exciting, I think, discoveries for me in this space, and I was very spoiled when I lived in Maryland with my team up there. My practice is still in that DC metro area primarily. So I have a lot of, we still have a lot of, you know, collaboration with those teams, but having my airway centric dentist had a PT, a PRI trained PT in the office, 2 different PTs, like twice a week, so that their patients going through expansion or, you know, having any kinds of issues were able to see the PT when they were there for their appointment. And so every time I went in for like an appliance adjustment, I also got to see the PT. I did see him between as well, because I only went in, you know, every so often. But it was incredible. It was absolutely incredible. And that's also one of the arenas that kind of really pinpointed for me that whole like tip of the tongue to toe connection, like how just from a fascia standpoint, we're so interconnected. And I would be like, I don't know what he did. I mean, I do know, I'm like, I can't explain it, but like, I feel like I got a full body massage. He barely like did, you know, barely touched me. And I just feel.
Did he do some of like the intraoral massage, like, or like the pterygoid
He did some
disease?
stuff in my palate, but like he did a lot like cranial and, you know, so he'd go to like other points on the body too. And he called it modern counterstrain technique was like part of what he did. He's like,
Counterstrain. Yeah.
Yeah. He's like, it's not the traditional counterstrain, it's modern counterstrain. And I know he works, Manny, who was treating me, works closely with Brian Tuckey, who's out of Frederick, Maryland, who's like just phenomenal as well. And the two of them are just these brilliant minds with amazing application for patients. And like, they get you out of pain so quickly, but it's, you know, then looking at, well, what's the root cause of this? What's causing this? And what is our team approach to make sure that we keep you in relief and not back, you know, sending you back into pain mode. And I know for me, right, like I'm low tone. I've always been low tone. That's a lifelong thing, right? I have a dowager's hump on the back of my neck from being, you know, sitting forward. So like my spine,
forward head,
you know, my spine is lovely. You know, I've had all these airway issues and orthodontic relapse and, you know, so on and so forth. I feel like can check all the boxes at some point or another. But I feel like finding a PT who got it was just absolutely life-changing. I mean, yes, the dentist too, but like the PT component, I was like, oh my gosh, like this is incredible. Like, how do we clone you and just like put one of you in every single dentist office? Like, how do we put you, how do we do this? Like, teach us your ways. And I did link up with PRI and, you know, and learned about a lot of, you know, they had me go through one of their trainings virtually during pandemic times. I watched it online and I was just like, this is so fascinating. Like, this is such a missing piece of the puzzle. So as a PT, I'm like, you have such a really unique perspective on, you know, the joints and the full body impact that I think a lot of dentists may not. And so I'm like, I can get why people would avoid the TMJ, TMD thing. It's kind of like what people avoid myo in general, as if our muscles don't exist. It's not something they teach us in grad school. Tongue tie, what's that? Like, we had to basically go learn all of this, you know, post grad. And in my opinion, like the things that are most important in life are things that we're all having to spend like, you know, thousands of dollars and hours learning ourselves and now trying to impart on others, because it's not simple, but it doesn't have to be this complex either. You know what I mean? Like, it's just like, I feel like if more of us come together, we can help more people. And so I love your whole, you know, like, let's all work together. And I'm like, yes, we just all come together. Like, we can all make such a big change. So I'm excited for, you know, the future.
Yes, I know. And I use like a lot of like muscle energy techniques too, which, you know, I think can be like really incredible, especially like for C1 too, because, you know, I think there's like a lot of incredible like chiropractors that are awesome at like fixing the alignment, but then patients are coming back and they're like, it's not staying, or like I'm unstable. And so you've got to be able to find ways to really like help retrain posturally what's going on, and, muscle movement, recruitment patterns. I love to geek out on that, and I love Pilates too, because like, it's also, about like alignment and like specific, like, let's try to fire multifidus and, and like stabilize your spine. And so I don't know, maybe I could start like a Pilates for TMJ.
Yeah. So that's basically, Manny was like, please don't do yoga. Please do Pilates. He was like, I want you to do Pilates reformer. He's like, that's where you need to start. You need to build some core strength. You need to get your lower back strength going. Like he, being a PT, like he looks at this stuff. And I was just like, oh, okay. Like that was why nobody ever told me that before. Like, why did I have to be 30, whatever, mid 30s before someone said, hey, do some Pilates. That's what your body needs. Cause nothing else was helping. Right. So I love that. Yeah. Start some kind of a, like, a Pilates thing for all of us in our myofunctional crises.
Yeah. I know. That's why I just like, to me, like, I love just like collaborating with other people. I just feel like that makes you stronger as a clinician. And, it's like, I'm just like an addict to like lifelong learning, like continuing like study clubs and like continuing education. And like you said, like paying for, a masterclass that is really like worthwhile, and is going to, take you to the next level. But I just really think, that is going to be like the standard of care, is where you're looking at all of those things. And we're not just like so siloed into like our one thing of like just the teeth.
Yes. I cannot wait for the day. I was just having a conversation with another dentist in the airway space. And we were talking about how like the gut microbiome 10 years ago was sort of like, what people were like, what's that? And those of us who were paying attention to it were crazy, right? And then it's all of a sudden, like now everybody's paying attention to the gut microbiome. And her whole thing was like the oral microbiome, like airway health, like how all of this, impacts our overall health, like maybe 10 years from now. That's right. What everybody will be talking about. And I'm like, we can only hope like that is the goal, that the TMJ, airway, myo, all the things. That would be wonderful.
Right. Well, and hopefully, we're in a world where dentists aren't just like fixing like cracked teeth from like, clenching and grinding. That we've gotten to kind of, like you said, the root cause of it is that we've like sorted all of those things out. And, I really feel like, you talk about like forward head posture, the muscles have that ideal length tension relationship. And if they're not there, and I think the same thing happens with the masseter, is like, if you lose that disc, and all of a sudden your condyles are seating further up into the joint socket, all of a sudden that masseter is scrunched closer together, the medial pterygoid, those are those elevator muscles, and they're not happy. No. You try to get under there and try to release that, and you're like, ah.
Oh yeah. No, we have like certain things in place where we're like, okay, if you see this on a patient, pause, don't ask them to repeat that, make a note and a referral. We never want to upset the joint. That's one of the things I think that is really beautifully discussed in the myo world, is like to protect that joint and to make sure we're not making it angry. And so there may be some dysfunction, there may be some, there may be an imbalance and whatnot, but if you have any concerns at all, or the patient complains, not just of clicking or pain, but if you notice something that makes you kind of go, like you're saying, we need to have more information before we just jump into a plan where we start addressing the muscles. And that's, one of the things, like you said, lifelong learner. That's one of the reasons why I created my membership. I was like, there really isn't a place right now where, and again, this was before the pandemic, but I was like, or kind of like in the beginning of it, I was kind of like, there really isn't a place where people can easily do this if they're not, if they don't do local study clubs, which I was doing with my team, but everyone was complaining that they couldn't source one, they couldn't find one. And I was like, well, why don't we all just kind of get together and learn together? And, being a lifelong learner, right? I'm constantly learning from colleagues in my space, outside of my space. And I think that's the beauty of all of this, and the inner, connection between everything that we're doing, because like you're sitting here talking about injury today, and I'm going, oh, wow. Yeah, that's new. That's new for me. I've been doing this for a while now. And injury directly to the joint. Yes. But like injury, not directly to the joint, that could still impact the joint. I was sitting here like, why didn't I think of that? Like Yeah. I
Well,
mean,
and it's funny too, is like, if you ask the question, like, have you had any injuries to like the head and neck? And people are like, oh no. And then you'll be like, well, what about this scar on your chin? Oh yeah, I fell and I busted my chin open and blood was everywhere and I had to get stitches. And, like, sometimes you have to ask very like specific questions. Like, have you ever been intubated, like surgery with a breathing tube? Have you had your wisdom teeth removed? All of those things. Like, have you been in a car accident? In my case, I was in 3 car accidents, and it all, like I said, that micro trauma becomes macro trauma to the joints. And we really need to understand that before we start fixing the teeth or putting in appliances or, and to me, like, once I discovered how to image correctly and to like really read those images. And again, I love beam readers. I think, I absolutely use them too, but I had to also learn how to read MRIs, right? That was a whole new skill. And so, that was really comprehensive curriculum to read that. But once I had that information, it took all of the mystery out of it, right? And it was like, I think as dentists, we would be like, you just put in like a night guard and like hope for the best, and like hope that patient doesn't ever come back, or like they come back and they're like, oh, it's making me worse. And like, you kind of just grind on it and like give it back to them and like hope that they don't come back again, but like if their joints are actively breaking down, that's when you see bite changes. And like, the biggest complaints are like something's in pain or something doesn't fit, right? And so if your bite is changing, or if you're starting to have pain, you're having limited range of motion, those are all like kind of those little like warning signs. And like I said, with our kiddos, I think that those are the things that we need to be like really like just popping up in front of our eyes, is like seeing those little subtle changes where, we might think like, oh, it's no big deal that they have a crossbite, or, oh, it's no big deal that they have that their front teeth don't couple together. They have an anterior open bite. No, it is a big deal.
And I think one of the things to look at too is sometimes you tell a child to smile, like my 4-year-old, and she brings her teeth bite to bite, like edge to edge, and she smiles, but that's not, into someone who's not trained, they're going to go like, oh, her bite's fine. And then we go, no, put your jaw where it's supposed to be. And she moves that lower jaw back, and it's trapped by her her mandible's trapped by her maxilla. And, it's like, it's scary. She's such a deep bite. She's grinding in her sleep. She's waking herself up. She's crying. She's, I'm like, she's not getting deep restorative sleep, which is a whole nother topic for another day. But, it's like one of those things where I'm like, oh gosh, like her joint, and she's going into treatment, but it's one, that's where I completely agree with you. Like, having the ability to do more early intervention instead of even waiting until 7, 8, 9, if we can, it's just critical because they're developing, and we need to catch these things when we can, and, try to implement what we can as early as possible. I always say to everybody, it's never too late to do something, but what that something might be, like you said, you might be at the point of surgery or something more involved. So like, it usually gets more involved, more costly, and takes longer to address the longer you wait. So I always say, get in early and see what you can do now.
Well, and what's so cool is like on the CBCT, you can see in a growing kiddo that the cortex of the condyle is fuzzy because that it's still growing. And so, there's like norms. If you're looking at the literature of like, if you have a 9-year-old boy, he should have like a 48 millimeter ramus height, and so then like you start looking at females and their growth center is completed by 15. So you've got this like little window, of time of where you can really, change, the amount of bone and the amount of growth that's happening with the mandible before it's too late, So I think that's where, CBCT and MRI, I think CBCT is great for really looking at the skeletal parts, but you've got to also put it together with the MRI and have those done with a bite registration so that you can correlate, is the joint healthy enough to support? Now I'm going to change the bite to that healthy position. And then, what ends up happening is like, if that disc is covering the growth center, then you take a repeat imaging, 9 to 12 months later, and you've gotten growth, you've gotten bone growing. I mean, that is what's so incredible. It's like you can grow like 4 millimeters of bone, it's like, imagine that, right? If you didn't have to do that with like a surgery or, if you could do that orthodontically with a functional appliance or, anything like that. But to me, again, you have to know the whole picture. You can't like miss those things. Because it can just, those are the cases, when I talked to my orthodontist, I was like, I want you to think about those cases that relapsed. What does that even mean? Why did it go sideways? Like, why did you have kind of this like subpar outcome, or even orthognathic surgery where you had like an MMA and you had an advancement and then it relapsed, right? It's because the joint wasn't stable. It was actively breaking down. So then they start, relapsing, and maybe they do like some chin augmentation and, some things like that, but really nobody's like paying attention to the fact that the joint wasn't stable or healthy to begin with. So that's kind of my whole thing, is like, let's create value for that diagnostic imaging early and comprehensively. And then like, let's all work together.
Yes, I love it. I love it. Well, thank you so much. This has been absolutely amazing. I can't wait to have you come join us in the Myo membership. And,
I would be honored.
Thank you for sharing also your son's journey and, everything you've learned.
Thank you. Thank you for having me.
Thanks for listening to this podcast. If you want to hear more of these Myo, TOTS, Airway, and feeding related episodes, be sure to leave a review on Apple Podcasts or pledge a small amount on patreon.com/the Untethered Podcast. If you found value, others in this space will too. So be sure to share this episode on your social media platforms and join us over on Facebook, on my Facebook page at Hallie Bulkin Biz, on Instagram at Hallie Bulkin, and you can head over to theuntetheredpodcast.com to grab a copy of the show notes, where you can also subscribe to be kept up to date on the latest podcast episodes.